Hey, this is Dr. Nick from the ECG Academy with the first of many Chalk Talks that will help you become an ECG expert. It's easy. Just log on to ecgacademy.com for basic instructional videos, while these Chalk Talks will help you get used to reading the more complicated tracings. Anyway, let's start with this one. It's one that we see all the time in the telemetry unit. Nurses, doctors will often sit there wondering what it is. And I'll talk you through it. So first look at the forest. There are 3 beats on the left side here that are kind of slow, and then there's these 6 beats on the right that are a lot faster. Well, if you look carefully at these beats, they kind of look like a normal beat. There's an upright P wave and a fairly normal PR interval of about 180 milliseconds. The QRS is a little bit wide. There's probably a little bit of an interventricular conduction delay there, like an incomplete right bundle branch block along those lines, and the T wave looks fairly narrow, nice and smooth. This beat looks exactly the same, and if we figure out the rate, let's start. It's about halfway between these 2 dark lines. So let's count off: 300, 150, 100, 75, 60. And it's a little bit to the right of where this one lands, so I'd say it's probably 59 beats per minute if you want to be exact, maybe 58. Look at the next beat over, count it: 300, 150, 100, 75, 60. And it's even further to the right, so I think 58 or 59 is perfect. And we would call this sinus bradycardia because it is less than 60 beats per minute, and it looks like it's coming from the sinus node with upright P waves and these 2 leads. Remember, these 2 leads are going simultaneously, so you can see the beats from a different angle. Okay, and then we get this weird kind of 6-beat run of something. It's fast. If you measure the rate, it's a little less than 2 boxes. So this is about 150 beats per minute. This may be 160. 165 or so, and then it slows down again. This is 2 big heavy boxes, so 300, 150. And this is a little slower, so it's a little irregular, averaging about 150 beats per minute. But the QRS complex is sort of wide and bizarre looking. It certainly doesn't look like the normally conducted beats. So let's figure out what it is. Well, most people realize, once you've read a bunch of EKGs, that a wide complex tachycardia like this is either non-sustained ventricular tachycardia coming from the bottom chambers, or some kind of atrial arrhythmia, atrial tachycardia or fibrillation, something like that, that is not following the normal conduction pathways in the heart, and it's what we call aberrant conduction. So it could be a supraventricular tachycardia with aberrant conduction, or it may be non-sustained ventricular tachycardia. So let's figure out which. And sometimes hard, but I think this will become clear to you in a minute. The best way to figure out whether this is coming from the atrium or the ventricle is to look at how it starts. What you're looking to see is if there's a P wave that sets off this tachycardia, and if the PR interval is normal, then it's likely coming from the top chamber. Well, keep in mind that P waves tend to be a lot spikier looking than T waves, and in technical terms, the frequency component of the electrical signal is much higher. In other words, the rate of change of voltage is much higher. The slope, let's just say, or the frequency content tends to be quicker than the T waves, which are more slowly changing electrical signals with a lower frequency content. So what you're looking for is a sharp, spiky signal on the T wave. So if you see a T wave that looks like this, or one that has a bite taken out of it like this, then chances are this high-frequency signal is a P wave. So let's go back and look, we'll pick a different color, and look at this normal T wave. Looks pretty smooth, and if you compare this T wave to it, it looks virtually the same. There's no high-frequency jiggle or any bite or anything that looks like a P wave. Same thing here. This T wave looks pretty smooth compared with this one, and I would say, no, there's no P wave. Now, some people would argue. They'd say, well, what about this? Could this little bump be a P wave? Well, I'll tell you why it's not. If you look at the bottom lead, you can see that the QRS complex actually extends back to here just before the heavy line. That's part of the QRS complex. So if you look at this lead at the same time, you can see that this first bump, this initial bump, actually is part of the QRS complex. It just happens to be rather small in the beginning, what we call isoelectric. So the QRS is wider than it seems, but that's not a P wave. Besides, the PR interval, if you measured it, would only be maybe 100 milliseconds, which is way too short for it to be conducting. Okay, so where do we go from here? Well, let's assume this is a ventricular beat because it's wide and bizarre and there's no P in front of it. Well, what you need to notice is this signal right here. This signal, which you can also see in this lead, is actually a retrograde P wave. How do we know that? Well, like I said, the T waves should be very smooth, and this sharp, spiky bite taken out of the T wave looks just like this. It's because this ventricular beat managed to get backwards up the AV node and back to the atrium, and the P wave is retrograde, meaning it's going in the opposite direction, and lo and behold, it's in the opposite direction than the normal P wave. That's what you'd expect in a retrograde P wave. Well, then what happens after that? You have this T wave and then another QRS complex, and then sure enough, there is another retrograde P wave. This time, the interval between the QRS and the P wave, this sort of interval is a little bit longer than here, and that's because the AV node really in general doesn't conduct that well in a backwards direction. The next beat that comes in looks exactly the same, but now look, there's no retrograde P wave because the AV node failed to conduct this signal backwards. If you continue examining these QRS complexes, you see that there's a retrograde P wave following this beat, and then the retrograde P wave disappears again. Finally, with the last beat of the tachycardia, there's a retrograde P wave. So if we count the number of QRS complexes, you have 1, 2, 3, 4, 5, 6. And how many P waves are there? 1, 2, 3, 4. So what we have here is a condition known as AV dissociation. AV dissociation means that there are more ventricular beats than there are atrial beats. The ventricle is running the show. That means this is indeed non-sustained ventricular tachycardia with variable conduction back to the atrium. AV dissociation, in fact, is the hallmark of VTAC because basically tells you that the ventricle is running the show and the atria are lagging behind. So the final answer is sinus bradycardia with a 6-beat run of non-sustained ventricular tachycardia that you can recognize because you have retrograde P waves and AV dissociation. Well, that's Rhythm Strip Chalk Talk number 1. I hope that helped. Stay tuned for more video Chalk Talks and log on to ecgacademy.com if you want to become an ECG expert. This is Dr. Nick from the ECG Academy with the second of many Chalk Talks that will help you become an ECG expert. It's easy. Just log on to ecgacademy.com for basic instructional videos, and these Chalk Talks will help you get used to reading the more complicated tracings. Anyway, this is number 2, and it's not that complicated, but number 3 will pick up where this left off, and I promise you it'll be more challenging. This one, if you look at the forest, you're looking at an irregular heartbeat here. And the question is it irregularly irregular, or is there a pattern of regular irregularity? And you should be able to notice right away that there is a group of 2 QRS complexes, and then there's a pause, another group of 2 and a pause, and then finally a group of 2. So there's group beating going on, and it makes you think that there may be some kind of conduction disturbance. Well, let's look more closely. Remember, these 3 lines are going simultaneously, so you can look at 3 different leads. And if you look at the first beat, it looks fairly normal with an upright P wave, a QRS complex, and a pretty smooth-looking T wave. The QRS is a little abnormal. There is a strange-looking wide S wave here. If you measure the entire QRS complex, it's only about 110 milliseconds. So this YS wave and this RSR prime in V1 suggests that there is an incomplete right bundle branch block going on, but that's something for a 12 lead to confirm. Anyway, the PR interval of this beat is about 200 milliseconds. It's at the upper limit of normal, right about one big box. The next beat comes along, and if we measure the rate, let's count off 300, 150, 100, 75, 60. So it's a little bit faster than 60, maybe 68 beats per minute. The PR interval still looks to be about 200 milliseconds, and the QRS looks the same. Well, if we measure off another 68 beats per minute, we find that there does seem to be a P wave that does appear to land on time, but there's no QRS associated with it. So it appears that AV block had occurred because this P wave never got down to the ventricles, and somewhere in the AV conduction system the signal never got through. Well, let's keep on going. Following this pause, there is another PR interval that's 0.2 or so, another one that's fairly constant, and then this P wave blocks. And so you have AV block with a fixed PR interval. Now, if we look at all different AV blocks, we remember that you have first, second, and third degree, where first degree all the P's conduct, as just your PR interval is a little bit long. With third degree AV block, none of the P waves conduct. Well, clearly some of them conduct in this tracing, so we have second degree AV block, and you should already know that with a fixed PR interval and no increase, that should be type 2 second degree AV block. Well, there are a couple of things you have to make sure. First of all, you have to make sure that this P wave is in fact on time and is not simply a non-conducted or blocked APC. So if you grab your calipers and move it on over to the P waves, you look at the P to P interval, and sure enough, this P does occur on time. In fact, all the P waves appear to be regular, and that is one of the requirements to say that second degree AV block is present, and that is the P to P interval should be regular. The other characteristic of type 2 second degree AV block is that the pause that results from the blocked P wave should be exactly 2 times the previous R to R interval. So if we take our calipers and confirm that we have them sized to reflect the R to R interval, now let's measure and take a look at it. Lands halfway between that box, and the next beat occurs exactly where it should. And that's because the P to P interval is constant, the PR is constant, and the fact is that this QRS complex lands exactly where it should land. If you look at the ratio of P's to QRS's, it's going to be 4 to 3 or 3 to 2 or 7 to 6. It's always one more P wave than QRS complexes. So the easiest way to figure out what ratio it is look at the QRS's, and that's the second number. So there are 2 QRS's, and therefore it must be 3 to 2 AV conduction with 1, 2, 3 P waves resulting in 2 QRS complexes. So pretty simple. Type 2 second degree AV block with a 3 to 2 pattern. But stay tuned for the next Chalk Talk, because I'm going to show you something that looks a little bit different. Hi, this is Dr. Nick from the ECG Academy with the next Rhythm Chalk Talk. Chalk Talks assume you know the basics. What I'm trying to do is get you used to reading more difficult tracings. You should also log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert. It's easy. And stay tuned for more Chalk Talks every week. Anyway, this is Rhythm Chalk Talk number 3, and I must say it's very challenging. A lot of cardiologists I know wouldn't get this right. But I'm going to help you work your way through it. And one big hint is that this is actually the same patient as Chalk Talk number 2. So that was a case of second degree type 2 AV block. And one big hint is that type 1 and type 2 second degree AV block almost never occur in the same patient. So at least not at the same time. So let's get to this. Remember to look at the forest, and the first thing I see is that the QRSs are irregular. Look for a pattern, right? So it turns out that these are regularly irregular with a group of 2, and then a little pause, and then another group of 2. And there's another QRS out here, which, you might think that there might be a group of 2, but you don't know for sure. And I'm trying to get you used to the fact that EKGs are not always perfect. And sometimes you'll just have one little strip to work with, and you'll just have to make the best of it. So once we've decided that there's group beating going on, that there are groups of QRSs, separated by pauses, you have to start to wonder, well, is this a case of AV block? Because conduction disturbances will cause pauses. So let's figure this out. Are there any P waves that we can see? Well, I think it's pretty clear to see that there are P waves that seem to be kind of just hanging out there, not followed by any QRS complex. So you would think that these P waves are non-conducted. And here's another one over here that seems to be non-conducted. So there's a pattern with a non-conducted P wave followed by 2 QRSs and then another non-conducted P wave and so on. And so let's review our classification of AV block. Because a lot of people would look at this and say, well, there's P's and there's QRSs and they're all over the place. Could this be 3rd degree, complete heart block? And the answer is no. In order to have 3rd degree AV block present, none of the P waves should be getting through. If none of the P waves get through, then the ventricular rhythm has to be some kind of escape rhythm. If you have AV block, then usually a low junctional focus or an idioventricular focus will arise as an escape rhythm, and the QRS complexes will be regular. These are not regular, so we know that 3rd degree AV block is not present. And it's clearly not 1st degree because some of the P waves are failing to conduct. So now we have to figure what kind of 2nd degree AV block is it. Well, let's look to see exactly what the P waves are doing, because we've seen these non-conducted ones, but what about some others? If you scan the tracing, you'll actually see that there's what looks like a P wave here in front of this QRS, and there's another one over here. So let's get out our trusty calipers and try to make some sense of this all. Well, first, we'll move the calipers to where we think there are 2 P waves in a row, and I've already adjusted the calipers to the right rate. And so what happens if we move this caliper over to the next beat, and you see that there's a P wave there that's just in front of this QRS complex. And if you measure back from this P wave, start here and measure backwards, you see that it lands on top of this P wave. So the P to P interval does indeed appear to be very regular. And if we figure out what rate it is, we can put our caliper on a heavy line. And let me write to the correct layer. So we'll count off 300, 150, 100, 75, 60. So it's probably about 65 or 68 beats per minute. All right. Let's get rid of these calipers. We don't need them anymore. So you have a sinus rhythm, because the P's appear to be upright. You have a sinus rhythm at 68 beats per minute, and some kind of AV block is going on. Well, let's try to figure it out. Now here's an interesting way of telling which P's conduct and which don't, because it's maybe a little deceptive sometimes. If you look at 2 of these beats, the beginnings of these groups, and let's just say that this was an escape rhythm. Okay, so let's find the midpoint between these 2 beats, and that would be somewhere around here. And so if this was an escape beat, an escape rhythm, and there was the P waves, none of the P waves were getting through, then a QRS would have fallen somewhere around here. But instead, what happened is this QRS was moved up. It occurred earlier. So that tells you this QRS had to have been conducted from above. This it makes sense because there is indeed a P wave in front of it. And interestingly, the PR interval here is about 0.2, which is around the same as the PR intervals that we saw in Chalk Talk number 2. Remember, it is the same patient after all. So I think it's safe to say, let me change my color just to, that this PR interval conducts, and then this P wave blocks. And then the question is, well, what happens here? And it does look like there's a P wave, but the PR interval is extremely short. Much shorter than you would expect if this P were to conduct. Remember, PR intervals generally can't get to be that short because the AV node is supposed to delay the signal a certain period of time. So it's unlikely this P wave conducted to this QRS complex. So where did this QRS come from? Well, it's an escape beat. That's exactly what it is. Think of it this way. This patient's AV node is not working, right? So this beat was conducted okay, but when this beat blocked, you have this long interval where there are no heartbeats, and the ventricles start to say to themselves, something, we gotta have to do something. We can't just let this person die. So an area in the conduction system fires as an escape focus because think of it this way, the normal escape rate of the AV junction is about, like I said, 40 beats per minute or so, and this is clearly lower than 40 beats per minute. So that would explain why the P and the QRS occur nearly simultaneously, and that's because this happens to be an escape beat. Some people would look at this and say, oh, well, this must be type 1, second-degree AV block, because the PR is short, and then it gets longer, and then it blocks. And someone told me that if the block is less than 2 times the previous R to R, so let me measure this. We'll get our calipers back and say, okay, here's the R to R of this beat, and we'll have to think of it being a little bit longer. And let's measure this pause. And the pause, indeed, yes, look at that. It's less than 2 times the previous R to R. So that must be wanky back. Well, the answer is wrong there, because this is one of the exceptions to the rule, because this QRS complex here is, in fact, not conducted. It occurs earlier because the focus in the conduction system fired prematurely and allowed this beat to kind of break the winky back rule. So if this is an escape focus, where did it come from? Well, you might think that it's a junctional escape focus, but did you notice that this QRS looked a little bit different from the conducted QRS complex? Yeah, this is the conducted beat, and this beat that follows the long pause, which we already are thinking that is an escape focus, looks different. So it's not a junctional escape. Let me try to explain what's happening here. So you've got your 2 atria, right? And then you've got your ventricles. And if you think of the conduction system as being the AV node, and then your His bundle, and then your bundle branches, the right bundle branch and the left bundle branch. Well, if the escape focus was in the AV node down here someplace, you would expect the QRS to follow the normal conduction pattern and be pretty much the same as the conducted beat. But instead what happens, because this patient has AV block, we've already decided this person has second-degree AV block, the AV node must be pretty sick. And even the AV junction is pretty sick and it's not generating the proper beat. But somewhere down here in the Purkinje system, there is a healthy focus that's taking over as the escape. And because the beat goes down one bundle and then has to go back up to the His and turn around to go back to the other bundle, it kind of distorts the QRS complex. And that's what's responsible for the change in the morphology of the QRS. All right, so to put it in plain English, this beat is not a junctional escape, but it is a bundle branch escape or a hemifascicular escape focus, and that's what makes it look different from the conducted beat. All right, so that is a pretty advanced concept, and I don't expect you guys to get it right away, but if you listen to this video a few times, and if you watch some of the videos that I posted on ECGacademy.com, I hope you'll understand the physiology. So what we have here is type 2 second degree AV block, since you really only have one PR interval that is conducted. Remember, this is the same patient who had type 2 before. You have a hemifascicular escape beat that makes the PR appear to shorten, but it's not really conducted. And that's really the nutshell of this tracing. It's pretty complicated, but I hope you'll at least take away some important lessons in how to approach this kind of very complicated ECG and how ECG experts will use the physiology to figure out exactly what's going on. So that's Rhythm Chalk Talk number 3. I hope that helps a little bit. Some of these Chalk Talks are going to be very basic, and some of them are going to be very advanced. So you get what you can out of each one. And if you log on to ECGacademy.com and go through all the videos, you'll get used to it, because after a while, it's just a matter of pattern recognition. So thanks for tuning in, and stay tuned for more Rhythm Chalk Talks. Hi, this is Dr. Nick from the ECG Academy with the next Rhythm Chalk Talk. The last one was really tough, and I know a lot of you may not have gotten it right away. But remember, Chalk Talks assume you know the basics. What I'm trying to do is get you used to reading more difficult tracings. This one won't be as bad. But don't forget, you can always log on to ECGacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert. And stay tuned for more Chalk Talks every week. Well, anyway, this, as I said, is an intermediate one. It's certainly not as bad as the last one. But let's just give you a little clinical background. Imagine this patient is being monitored for some postoperative problems, and the nurse calls that the patient all of a sudden has developed a heart rate of about 40 beats per minute. And you have to look at the EKG and figure out what's going on. Well, you look at the forest, and the QRS complexes certainly seem to be regular. And if you measure the rate starting at this heavy line and count off 300, 150, 100, 75, 60, 50, it is 40 beats per minute or so. That's pretty accurate. So let's see, are there any P waves? We can see P waves. Yes, indeed. If you look in front of the QRS complex, you see what looks like a normal P wave in front of every QRS. It's upright. The PR interval measures about 180 milliseconds or so. So that seems to be normal. So one of the more likely possibilities is that this is sinus bradycardia. And sinus bradycardia occurs commonly postoperatively, and you'd be tempted to just say, okay, this is sinus brady, and treat the patient accordingly. But there's something going on here that's more than just sinus brady, and that's what these Chalk Talks are all about, getting you used to looking for things out of the ordinary, things a little more advanced than what you'll see in the textbooks. Okay, and I'll give you a hint. Remember that the electrical characteristics of a QRS complex, in particular P wave. Let's start with the P wave. The P wave voltage changes relatively rapidly. If the rate of change of a P wave is fast compared with the T wave. let me just put that in plain English. P waves look a little more spiky because in technical terms, the frequency content includes a lot of higher frequency components, whereas T waves tend to be lower frequency electrical signals with slower rates of change of voltage, so they're more smooth and gradually changing in voltage. All right, so that's a clue. When we go back to this EKG, we'll change color just to provide a little contrast. Here's the P wave and the QRS, and everything looks fairly normal. But when you look at the T wave, it's by no means smooth. These T waves are very bumpy. It looks like a camelback. And what you need to be able to recognize is that this is clearly a very abnormal looking T wave. And it looks abnormal because there is a P wave superimposed on top of the T wave. This P wave doesn't conduct, so there's no QRS following it. And so you think, oh, block P waves. Well, this must be AV block. No, that's not quite right. Because in order to be able to diagnose AV block, you need to be able to demonstrate that the P to P interval is regular. And if you take this P wave and you take the next P wave and you measure halfway in between, indeed there is nothing there. And so that you might say, well, there's no P wave here, but maybe we got the P wave rate wrong. So let's measure from this P wave to this one. Where would the next one fall if that was the atrial rate? Well, it would fall in here someplace, and then maybe have another one over here before you came to this P wave. So neither of those cases are true. So what is this then? How would we classify this P wave superimposed on the T? Well, it's not on time, it's early. So in basic terms, it's a premature atrial beat, or a premature atrial contraction, or a PAC, or an APC, whatever you want to call it. It all means the same. It's an atrial event that occurs earlier than it should. Now that can occur. Remember that the atria are made up of electrically active cells, and any cell in the atria can give rise to an electrical signal. When you're post-operative, there's lots of adrenaline circulating around, and so areas in the atrium can fire. And you can have an electrical signal that gives rise to a P wave, and that's what we are seeing as a premature atrial beat. Well, but it didn't conduct. Why didn't it conduct? Well, remember that the AV node takes some time to recover from the previous beat. It has a certain refractory period. So after this beat conducts down the AV node, there's a certain period of time where the AV node is busy conducting that beat to the ventricle, and it takes a split second to recover. So when this P wave hits the AV node, it finds that the AV node is not capable of conducting the beat properly. And so the AV node fails to conduct the beat, and you get a P wave that blocks. Well, I don't like the word block because it implies that something is wrong, that the AV node didn't behave normally. But in fact, premature beats like this commonly don't conduct, and it's sort of normal behavior for the AV node, because the AV node, in fact, acts kind of like a safety valve, and it prevents very rapid electrical rhythms like atrial fibrillation and flutter from being conducted down to the ventricles at super high rates. So the AV node's kind of like a funnel. Think of a funnel as a device where you can pour lots of water into the top of it, but only a certain amount is going to come out the bottom. So the AV node's like a filter or a funnel, and it filtered out this P wave because it was just too early. So then, what do you make of this rhythm strip? Well, officially, what we would call this is atrial bigeminy. Why? Because every other beat is premature. You've heard of ventricular bigeminy, where every other beat is a ventricular premature beat. Well, this is atrial bigeminy, where you have a normal beat and then a PAC, and then a little compensatory pause, and then a normal beat and a PAC, and another compensatory pause. So you have atrial bigeminy, but the PACs are blocked, or shall we say non-conducted. So what I like to call this trip non-conducted atrial bigeminy, and it's responsible for the fact that the ventricular rate suddenly went to 41 beats per minute. But there's nothing wrong with the sinus node. It happens to be the atrial myocardium that's the problem, because of all those post-operative hormones running around. You've got just a lot of atrial ectopy. And in the absence of symptoms, we generally would not treat this. In fact, some people would add an antiarrhythmic drug if it gets to be too slow, but that's really not necessary as long as the patient is hemodynamically stable. So it was an interesting strip. I hope you enjoyed that. These Chalk Talks, as I said, are designed to get you looking at things that you normally won't see in a textbook, and to get you comfortable with reading more difficult tracings. So I hope that helped. So remember to log on to ecgacademy.com so you too can become an ECG expert. Hi, this is Dr. Nick from the ECG Academy with the next Rhythm Chalk Talk. Remember, Chalk Talks assume you know the basics. What I'm trying to do is get you used to reading more difficult tracings. You can also log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert. It's easy. And stay tuned for more Chalk Talks every week. Anyway, this rhythm strip is something that I found on the telemetry unit, and it's a very common strip. It's a common arrhythmia, but so I listed it as basic, but it doesn't exactly look like the typical textbook picture of this particular arrhythmia. So that's why I thought it would be fun to go through it step by step and teach you how to recognize this arrhythmia while when you're looking at strips on the units. Anyway, let's look at the forest first. You see the QRSs kind of marching through, and they look pretty regular. Let's grab our calipers and take a look and see whether they are indeed regular. So put them down. I happen to have them at the right rate. And the QRSs certainly do appear to be very regular. So, that's kind of interesting. What's the rate there? If we count heavy boxes, 300, 150, 100, 75, 60, it's between 60 and 75 beats per minute, so we'll call it 68. Well, that's fine. So we have a regular rhythm at 68 beats per minute, and now, of course, what should we do is look for atrial activity. What's the atrium doing? Of course, the best place to look for P waves is in front of the QRS complex. And if you look in front of this QRS, there's a bump right here that kind of looks a little like a P wave. Let's look at the next QRS complex, and it seems like there's the same signal there. In fact, there's a bump in front of every QRS complex. But if this was a P wave and you were to measure the PR interval, it would seem to be somewhat short. Perhaps 120 milliseconds or so. Well, what's the normal PR interval? The normal PR should be 0.12 to 0.2 seconds, or as electrophysiologists like to think in terms of milliseconds, 120 to 200 milliseconds. Or for beginners, it's basically anywhere from 3 to 5 small boxes. And that would be the normal PR interval. This really does look short, doesn't it? It's almost like 2.5 small boxes, really. It doesn't quite make 3. So you'd have to call this sinus rhythm with a short PR interval. But when you think of short PR intervals, well, there are a couple of syndromes that come in mind, like WPW syndrome, where you, instead of having a PR segment that's fairly flat, what you have instead is a delta wave, which is slurred upstroke of the QRS complex and a very short PR. But that's not really what we're seeing here. We're seeing just a short PR interval. But here's the trick. You really shouldn't just look at this. You really have to look at the whole thing. Because if you kind of glance at the baseline between these QRS complexes, there's a hint here. Because in front of this little bump here that you think is a P wave, there's a flat segment, but it's not exactly flat, is it? It's kind of slanted. It has a slope to it. So when you think about slopey things, what you need to think about are sawtooth waves. What does a sawtooth wave tell you? Atrial flutter. Now, how do you know it's atrial flutter? Well, if you look really closely, behind this bump, there's actually another bump that looks just like it, right there. And if I take out my teeny weeny calipers and bring them on over, you can see that, well, my marks got in the way of that one. Let's measure these over here. You have these two, which are a little bit slower than 300 beats per minute, probably about 275 beats per minute. And then if you measure on over, you see that there's actually a bump on the very beginning portion of the T wave. And so if you put your caliper lines on that, then you're reading the end of the T wave. And if you measure out after that, you see the next bump here, which is a flutter wave, occurs on time. All right, so when you're thinking about flutter waves, we're seeing one, we're seeing two, then there's one buried in the beginning of the T wave, and there's one buried at the end of the T wave. So you have to consider there's 4 flutter waves for every QRS complex, and it just keeps repeating over and over again. So you could call this atrial flutter with 4-to-1 conduction. I don't like to use the word block. The word block implies that there's really something wrong with the AV node, and realize that the AV node is supposed to keep all of the atrial signals from the ventricles, because if you had an atrial rate of 275 beats per minute and the AV node conducted every single one, you'd have a ventricular rate of 275, which could kill a person. So your AV node kind of acts like a filter, and it keeps all the atrial signals, very rapid ones, from reaching the ventricle. Well, in a normal person, perhaps in the middle of the night while they're sleeping, you could easily have atrial flutter conducting here at 68 beats per minute. Think of 68 is about 70. 70 times 4 is 280, and that's kind of where we thought our atrial rate was, about 275 beats per minute. So if the atrial rate's 275, 1/4 of that runs out to be about 68 beats per minute, which was kind of where we thought the ventricular rate was. So it all adds up. You've got atrial flutter with 4-to-1 conduction. Some people would just call this a moderate ventricular response, but these flutter waves are a little bit tougher to see. It's fairly basic. Most people should be able to pick those up, but 2 of them got hidden by the T wave, and that's why I thought this strip was a little bit more challenging than the ones you'll normally see. So that's Rhythm Chalk Talk number 5. I hope that helped. Remember to log on to ECGacademy.com so you too can become an ECG expert. And thanks for watching. Hi, this is Dr. Nick from the ECG Academy with Chalk Talk number 6. Now, I want to get right into this one because it's a great tracing. It's a common problem that most people don't think about. And I want to introduce it to you here on our 6th Rhythm Chalk Talk. So let's get right to it. The first strip are 2 leads running simultaneously, and then you have a second strip from the same patient. And if you look at the first strip, you can see a fairly normal, regular-looking EKG with a P wave and a QRS complex and a nice-looking T wave. if you measure the rate, let's take this one, we can count off 300, 150, 100, 75, 60. So it's a little bit faster than that, about 64 beats per minute on this beat. And so it would look like a normal sinus rhythm. It's a little irregular though, and so let's take our calipers out and measure it. I set these calipers up for about 64 beats per minute, and what you see is the first R interval is actually a little bit longer, and then it comes down to the 64, and then it looks a little bit faster. And this R interval is a little shorter, as is this one, and if you measure this one shorter, and then it gets longer again. And so what we have here is a very common abnormality known as sinus arrhythmia. It's a slight irregularity in the sinus rhythm, and it happens because the sinus node is influenced by changes in the autonomic nervous system. The vagal nerve in particular will cause changes, very rapid changes in heart rate that can cause the R-to-R interval to vary from one beat to the next. But this is normal. Sinus arrhythmia is considered a normal variant. So now let's get to the second strip. If we, well, let's look at this T wave, and the T to T appears to be regular. And if you place it on the caliper on this QRS complex, you can see that there seems to be a QRS right here that is probably on time. This one here, I would say. And then you have what looks like this 7 beats of a rapid, irregular-looking signal with a rate that's, let's count it off, 300, 150. So it's about 165, maybe 170 beats per minute, but it's grossly irregular. It comes down to 150 here. And you're not really sure what it is, but you think, maybe this is a run of non-sustained ventricular tachycardia. Once this is over, you see that the normal sinus rhythm comes back again, in fact, very quickly. But you know, what bothers me, the first thing that bothers me is if this is a QRS complex, and it looks like it, because it looks a lot like this one, and it occurs on time, how can a PVC start so soon after the QRS? In fact, it almost seems to start with the QRS complex, right? On the top lead here, that doesn't make sense. And then if you kind of look through this tracing, you see something. In fact, you see this signal. That looks just like this. So you start to wonder, is this real or not? Well, let's get our calipers back out again. And if we map out these signals, given that there's a little bit of sinus arrhythmia and you'd expect a little bit of irregularity, there seems to be something that's right here. And if you bring our calipers back out, this beat occurs on time. With plus or minus a couple of small boxes, but remember there's a little sinus arrhythmia going on. So what do we have here? This is artifact. In other words, our EKG systems are picking up little tiny electrical signals coming from our heart. But since the EKG electrodes are on your skin, it can pick up other things. It can pick up your muscles. It can pick up your scratching yourself. If someone shakes the wires, those signals can be picked up. And all those things are artifactual. They're not real. They're not really the EKG. They're just external interference. And that's what this is. It's artifact. And as such, it should be ignored. You wouldn't put a strip like this on the patient's chart. You just throw it out. You have to recognize that this is not real. Why? Well, this first signal here started on top of the QRS, which physiologically can't happen. You also have a regular QRS in the middle of it, and you can't have a regular normal sinus beat in the middle, sandwiched between two beats of ventricular tachycardia. It just can't happen. So keep this in mind when you read the strips, because I promise I'm going to show you more of these artifactual strips. But this is a great lesson to be learned, and I hope you keep this in mind, that not everything on paper may be real, and you have to recognize that there are limitations in the technology that we're using. So that's Rhythm Chalk Talk number 6. Remember, log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert too. Hi, this is Dr. Nick from the ECG Academy with Chalk Talk number 7. Remember, Chalk Talks assume you know the basics, but I've labeled this strip as advanced because we're going to be talking about some advanced physiologic topics in this tracing. And remember, it's important to understand the physiology because that allows you to read much more complex tracings. So let's get started. This is a Holter monitor that I picked up. And it's 3 simultaneous leads, of course. So we're going to get started with looking at the forest. And I think what stands out very clearly in this strip is that there's a pause here. There seems to be a regular rhythm going along. And if we try to measure the rate, let's start with this heavy line. We'll call it 300, 150, 100, 75. It's just about 75 beats per minute, just exactly. So we have the regular rhythm of 75 beats per minute. If you happen to notice, the QRS complex is rather wide, so there looks like a bundle branch block is going on. The duration is at least 160 milliseconds. And when we start looking for P waves, we can look in any leads, and I think it's clear to see that there does appear to be a P wave in front of every beat. And if we take out our little mini calipers and look at the PR interval, it looks like the PR interval is just about 200 milliseconds, and it looks to be quite regular. Let's see, is it 200? Yeah, it's just about 200. And then what happens is, it looks like there's a P wave here that doesn't get conducted. Well, all right, let's explore this a little bit further. We'll take our big calipers, and we'll move this up here and see if the R to R intervals are regular. And in fact, they do appear to be regular. And then let's see what happens with the next beat. When we put the calipers down, it looks like the QRS comes right on time. Now that's interesting. And they keep on going. So we have a P wave that appears to have not conducted. We'll get rid of that and start drawing. So we have regular PR intervals that are fixed, and we have an R to R interval, a pause, that's 2 times the previous R to R interval, and then the next PR interval following the pause is the same. Underlying, you've got this bundle branch block. And so people would be tempted to think that this is what? Type 2 second degree AV block, like Mobit's 2 block, because you have a fixed PR interval, you have a P wave that fails to conduct. The R to R is exactly the same as 2 times the previous R to R, so it all fits, right? So, geez, I should have labeled this basic. Well, that's not the whole story. And we'll have to go back and talk about how to look for small details. Remember, first you look at the forest, then the trees, but it's the small details that will give you the answer every time. So what does the ECG look like? You've got this P wave that has high frequency signals because it looks kind of spiky, and then you've got T waves that have a very low frequency signal content, and it looks very smooth. And if you look at these T waves, I beg your pardon, they look very smooth. And you see this one here. Now, what's interesting is there's something kind of in the tail end of that T wave. And if you look at this lead, this T wave appears to have this particular shape. I don't know what you might call it, a biphasic shape. And then this T wave, the shape kind of changes a little bit. It kind of goes up a little at the end. Well, what is that? Well, this is the lead that shows it the best. This is a P wave. That's right. Maybe you didn't notice that before. Maybe you guys who are good at reading EKGs might have picked that out. But here's a P wave. Now, what the heck is that? It doesn't exactly come on time because the P wave should have landed here someplace. So what is it? It's a premature atrial contraction, or an APC, or whatever you want to call it, but it's premature. And it falls in a point after the T wave, and it obviously doesn't conduct. Well, blocked PACs, or non-conducted PACs, occur quite frequently, and we don't really think much of it. But there's a concept that you have to understand in this video that I want to get across, and it's called concealed conduction. Concealed conduction is an electrophysiologic phenomenon that allows us to see conduction into a part of the cardiac conduction system that's not apparent. Now, what do I mean by that? Well, let's just kind of review a little bit of the physiology here. Okay, this is an animation that I put together in the good old days. And what you have here in the high right atrium is the sinus node that fires, and you have atrial depolarization that spreads across both atria. Remember, there's a Bachman's bundle behind the aortic root that connects the two atria together. And then here you have the AV node, which its job is to delay the signal slightly. That gives the atria a chance to contract and push the blood through the heart valves. So there's a little bit of delay that's supposed to be there. Remember, normal PR interval should be 120 to 200 milliseconds. And then the signal propagates down the His bundle in the Purkinje system. Okay, but the AV node has a very interesting behavior. Let me get rid of that. With the AV node, I'm going to erase this stuff here for a second. And with the AV node, there is a period of time after the AV node fires where the AV node cannot accept another signal. Remember, at faster rates, the AV node conducts worse. That's why with fast atrial arrhythmias, you can get conduction block. And that's because the AV nodal cells have a special characteristic known as decremental conduction, which means that the faster you stimulate it, the worse it conducts. And that has to do with the fact that the AV nodal cells conduct or bring calcium into the cell, and the calcium currents are the predominant means of the cellular depolarization, remember, with the action potential. So the upstroke of an AV nodal cell is relatively slow because it's a calcium-dependent cell, and because of that, if you bombard the AV node with rapid signals, those signals will not get down. So, of course, this early atrial event hits the AV node at a point when it's refractory and it won't conduct. It says, nope, I'm sorry, I'm busy conducting the last one. I'm not ready to take this one yet. Okay, no big deal. PACs frequently block. But then why did this beat block? Why did this atrial event fail to conduct? It made it look like that this was a second-degree type 2 AV block, but it's not. And the reason is this concealed conduction. The idea behind concealed conduction is that if one impulse, let me pick a different color, if one impulse gets into the AV node, it may penetrate partially into the AV node, but then fail to exit the other end of it. But the fact that it got into the AV node, even for a short period of time, it leaves those AV nodal cells refractory. It means that those AV nodal cells have to wait a whole nother cycle before they will conduct the following beat. And so we call this concealed conduction. It means that this beat got into the AV node and it left the AV node refractory. Even though it didn't come out the other end, its effects are still present because when this beat comes down, the AV nodal cells have remained refractory and this beat blocks as well, even though there was a long interval between this last conducted QRS complex and this P wave. Okay, so this fooled you. What you really have here are two PACs, because if you looked really carefully, this P wave actually looks a little bit different than this P wave, and it occurs a little bit earlier than we'd expect. If I didn't want to show you that with my calipers because it might have given it away. So what you have are two premature atrial events, both of which encounter a refractory AV node. So what you really have are two blocked PACs in a row, two sequential non-conducted PACs, and it's not true AV block in the strictest sense of the word. And so although it appears to be second-degree AV block, it's really not, because the AV node is kind of behaving normally. Now, it's possible that this patient has some significant AV nodal disease, and it's even possible that the block occurred further down in the conduction system. I'm not saying that that's impossible, but what I'm saying is that if you're going to read an EKG diagnosis, in this case, we're not really dealing with true second-degree AV block. You have to recognize that this P wave throws the whole thing off. So that was the little hidden fly in the ointment, so to speak, that that you need to be able to recognize and label this strip correctly. So that was kind of fun, and I enjoyed showing that to you. I hope that helps you understand the cardiac physiology a little bit better, and that's what I'm trying to do with these Rhythm Chalk Talks. So tell all your friends to log on, subscribe to my channel. I'd like to really try to get my videos to be #1 on the internet. So help me out, and keep watching for more Chalk Talks, and remember to log on to ECGacademy.com so I can help you become an ECG expert too. Hi, this is Dr. Nick from the ECG Academy with the next Rhythm Chalk Talk. This is number 8. Now, I've labeled this as basic because this is an arrhythmia that you will see fairly often. This ECG isn't that hard to interpret, but I'm going to talk about some other physiologic and electrocardiographic ideas that might help you understand other tracings in the future. After all, that's what we're trying to do, is give you some practice in reading some of these advanced tracings. So we'll get to it. This is a bit of a departure from my usual rhythm strip because I'm showing you the whole 12 lead, but down here there is lead 2, which is a rhythm strip that you can kind of take a look at. Look at the whole forest, and you can see that it's a little slow in the beginning, and then it seemed to speed up a little, and then it gets slow again at the end. So that gives you an idea that the rhythm may be changing here. So let's examine these ECG beats in detail. We can see an upright P wave in 1, 2, and 3, a normal PR interval of maybe 160 milliseconds, and then the QRS complex looks pretty normal. The T wave does as well. So now look at rate, and if we look at this S wave that lands on a heavy line, we can count off 300, 150, 100, 75, 60, 50. This is exactly 50 beats per minute. And so if the P wave is coming from the normal sinus region and we have 50 beats per minute, we can diagnose sinus bradycardia. Pretty simple, right? But if we go down to our rhythm strip, we can see that this third beat, something changes. The P wave looks different. It looks upside down. It's an inverted P wave in lead 2. And that kind of makes you think that the P wave is coming from somewhere else in the heart. After all, axis gives you an idea of direction. And if the P wave changes its axis, then usually that means the P wave is coming from a different spot in the atrium. So what else do we see? Well, let's bring up a pair of calipers and examine the rate. And if we bring this caliper down to the first beat, I've set it for 50 beats per minute, which is the P to P interval of the first beat. But if we bring this over, we can see not only does this P wave change its axis, but also comes a little bit early. And so this is an ectopic beat coming from some focus in the atrium. We're going to discuss that a little bit later. And if we take another pair of calipers that I've set for the P to P interval here, which if you count back, be about 300, 150, 175, 60, maybe 66 beats per minute, then you can see that the next P to P interval actually speeds up a little. And that so the rhythm kind of warms up. It goes from 66 to maybe 72 beats per minute. And then after this last beat here stops, and then the normal P wave comes in after a bit of a pause. Okay, so get rid of our calipers and start talking about the P wave. Now, not only is it inverted in 2, but it's inverted in AVF. but it happens to be upright in AVL, which makes you think that it is headed from left to right. Well, what do you mean? I mean from right to left. Are we getting confused? Well, in that case, then why don't we look at axis and kind of review what axis is all about? Axis has to do with the vertical plane, or the so-called frontal plane, and it has to do with the limb leads. So we can divide up this 360-degree circle into equal parts, and the first leads 1, 2, and 3 are pretty simple. Lead 1 is going from right arm to left arm, and that's designated as 0 degrees. And then we have to divide with leads 2 and 3. We have to divide the circle up into equal parts. So where does 2 go? Well, 2, 3, and AVF are the inferior leads, so it's going to point towards the bottom part of the circle. But at what angle? Well, I always tell people to remember that in English we read from top down and from left to right. And so if you draw a line 60 degrees above the horizontal, because we do have to split the circle into 6 equal spaces, and this will be lead 2. And then, of course, lead 3 would be the last one. Since it's an inferior lead, it also points towards the bottom, so that's lead 3. And so you've got your first 3 limb leads in here with leads 1, 2, and 3. Now, where do the augmented limb leads go? Well, AVF, which is also an inferior lead, goes straight down. And that's where plus 90 degrees is. Let's see, this is AVF, and that's plus 90 degrees. AVL is going to point towards the left arm, so that comes up here. And then AVR is the only one sort of like kind of an odd lead because it sort of points in the opposite direction than all the other leads combined. That's why most signals are negative in AVR, because P waves and QRSs tend to point down and to the left towards the apex, and that's going away from AVR. So when a signal is going in the opposite direction than a lead, let's say AVR, if the signal is going down and to the left away from AVR, then it's going to be drawn as a negative deflection on the ECG. All right, so what does that mean in terms of our P wave? Well, here is, let's just erase this, and here's a drawing that I made of the heart. And here's your sinus node up in the right atrium. Your left atrium is a little bit higher than that and to the left, but when the sinus node fires, the signal spreads to the left and down, which is why P waves in a normal sinus rhythm tend to be positive in the inferior leads, and they're also positive in 1 and AVL, because the signal is traveling towards 1 and AVL towards the left. But now in this ECG, what you see is that the P waves are negative in 2 and they're positive in AVR. That means that this signal, this P wave, is arising from some crazy place. It likely is arising from the low right atrium somewhere, because it's heading towards AVL, where it was positive. The P wave was positive in AVL, but it's also positive in AVR. So it's traveling in those two directions, and of course it's going away from 2, 3, and AVF. It's arising from the low right atrium and traveling towards the head. So that tells us that's an ectopic focus somewhere in the low right atrium that takes over the rhythm. Well, let's go back to this and see what we're talking about. So you have this, by definition, an ectopic atrial rhythm. An ectopic atrial rhythm that is a little bit faster than the sinus bradycardia that's here. The P wave changes because the axis of the P wave is headed up and towards the right, but it's also positive in AVL, so that's why I think it's coming from the right atrium, since it's going towards AVL as well as towards AVR. So you have this ectopic atrial rhythm that has a little bit of a warm-up, because it starts out sort of slow and then builds up a little bit. But then after this ends, you have a fairly long pause. And that's pretty common, because we have this concept of overdrive suppression. Overdrive suppression is an electrophysiologic concept that any area in the heart, whether it be in the atrium or the AV node or Purkinje fibers or even ventriculomyocardium, is able to fire. It's able to deliver electrical signals. It has something called automaticity. But if another region of the heart is firing faster, then that automaticity is suppressed. That's why you don't have these ectopic atrial beats all the time, because the sinus node usually keeps them suppressed because the sinus node tends to fire faster. But here, what do we have? We have a sinus bradycardia. It's very fast. It's very slow, I mean to say. And so that allows some of these ectopic atrial foci to gain footing and create these arrhythmia problems. But when the ectopic atrial focus stops firing, then it takes a little while for the sinus node to kick in again because of overdrive suppression of the sinus node. We see this commonly in sick sinus syndrome, where you have a tachyarrhythmia and then post-tachycardia pauses. The common cause of lightheadedness in patients with tachybrady syndrome. All right, so I think the other thing to point out is that in this 12 lead, you do have an RSR prime pattern in V2, a little bit of it in V1, but the QRS complex isn't wide enough to really qualify for a bundle branch block, but this allows you to diagnose an incomplete right bundle branch block. All right, so what you have is sinus bradycardia with a run of an ectopic atrial rhythm that has a little bit of a warm-up there, and an incomplete right bundle branch block on the 12 lead that is worth mentioning, and a little bit of a sinus pause after this arrhythmia that's probably due to overdrive suppression, and this patient may be on medications or may have a degree of sinus node dysfunction, but it's a common presentation in someone who may have symptoms. On the other hand, it may be asymptomatic, so you have to take the patient as an individual. Anyway, I hope this was interesting to you. I hope I've clarified some concepts in terms of axis and rhythm, and I enjoyed showing this to you. And remember, log on to ecgacademy.com so you can watch videos from basic to advanced, and you too can become an ECG expert. Oh, and subscribe to my YouTube channel so that you get notified when I put up my next Chalk Talk, which will be soon. Keep watching, and thanks for viewing. Hi, this is Dr. Nick from the ECG Academy with Chalk Talk number 9. Chalk Talks assume you know the basics, so what I'm trying to do is get you used to reading more complicated tracings. And this time I'm going to do it a little bit differently. We're going to talk clinically, okay? Because a lot of you will have to take board questions, and I want you to get thinking along those lines. So let's imagine a case, okay? And this is a 59-year-old woman who has a history of depression, and she's on Effexor, and she gets a urinary tract infection with fever and chills and so forth, and gets admitted to the hospital, and her doctor puts her on an antibiotic commonly used, let's say Levaquin. And then in the middle of the night, the nurse calls you up and says, you know, something funny happened on the monitor. I wonder if you can take a look at it. And here's the rhythm strip they give you, and here's the question. What do you do? Okay, do you A, go back to sleep, it's only artifact? Do you B, give IV cardizem? Would you C, give IV amiodarone? Or D, none of the above? So let's get to it. Let's get rid of these, and let's start looking at this tracing, because it is pretty bizarre, and that's why I didn't make it basic. It's kind of an intermediate tracing. When you first look at it, you kind of have to look at the forest, because there's almost no pattern to this, and you see all these really weird looking beats over here, and it kind of does give a sense of artifact. And imagine if this is a very itchy patient. She's probably scratching herself all over the place and giving you all these numbers. But all these beats, but let's look more carefully, okay? Shall we look at the trees? So these first couple of beats, they really do look wide and bizarre, and I mean, they certainly could be ventricular beats because of that, but lo and behold, oh my goodness, thank goodness we actually found a normal looking beat. So we have somewhere to start. You have a nice looking P wave. We have a PR interval that's fairly normal. It's almost 0.2, I'd say, and a QRS that's narrow. And so great. So now we have, after a short pause of maybe 600 milliseconds or so, we have the beginning of this run of something. And the first beat almost kind of looks like the normal beat, except the R wave's a little bit taller and it looks a little wider, and I'm not really sure about that. But then you've got these wide, complex beats starting at a rate of about maybe 160 beats per minute, and then it speeds up somewhat. It gets to be, almost 180, close to 200 beats a minute at the end. And then it seems to change, doesn't it? You have these wide beats, and then it kind of changes its appearance, and now you've got these funny, crazy-looking beats, and then it finally stops, and you get another normal beat. Now the PR is a little bit long here, but I'm not going to make too much of that because all of a sudden you've got a couple of wide beats again, and then a normal beat once again, and then a run of a wide, complex tachycardia. If that's what it is, if you're convinced it's not an artifact. I mean, when you scan around, you don't see anything that looks like a normal QRS peeking out from any of these beats, so let's assume it's not artifact for the time being. Here's another QRS. This time the PR is a little bit shorter, and then there's 4 beats of this wide something or other, and then another normal beat, and probably a P wave here. That's another normal beat. So, oh my goodness, 2 normal beats in a row. I guess we can figure out what the sinus node is doing. Okay, so if we measure out the rate, we get 300, 150, 175. It's between 60 and 75, closer to 75, so maybe 68 or 70 beats per minute, assuming this conducts. Okay, here, I'll make you feel better. Okay, is that better? All right. Anyway, all right, so we've got a sinus bradycardia, or barely a sinus rhythm, but then we have these wide, complex tachycardias. All right, so when we're figuring out where a wide, complex tachycardia comes from, what should we be looking for? Well, how does it start? Is there a P wave in front of the first beat? Because that's a really important clue. If you see a P wave with a normal or a slightly prolonged PR interval, then it's most likely atrial, and you start to think about cardism for some kind of atrial arrhythmia with aberrant conduction. So if we kind of look at the T wave of this beat that precedes the tachycardia, I don't know about that. I don't see any bumps or bites or anything high frequency that I would call a P wave. Remember, atrial activity on top of a T wave is usually easy to see, but I just don't see it here. So if there's no P wave in front of this beat, then the presumption is that it's ventricular. But if it's ventricular and you have rates in the 150 to 200 range, we're talking about ventricular tachycardia. Well, let's think about VTAC for a little while and kind of remember the classification of VTAC when you're trying to make an electrocardiographic diagnosis. You have several different varieties. So you have monomorphic ventricular tachycardia, and that, of course, is where all the beats look the same, at least in the same lead, right? If you look at a different lead, it's going to look differently, of course, but monomorphic means all the beats look alike in one lead, so it's the same morphology. Polymorphic ventricular tachycardia is a ventricular tachycardia where the beats seem to change over time, and you may have at least 2 different morphologies during this run of ventricular tachycardia. So that's called polymorphic VT. Now, these are generally at rates below 300 beats per minute. When you get to rates above 300 beats per minute, then the names change a little bit. A monomorphic ventricular tachycardia at above 300 beats per minute is often referred to as ventricular flutter. Think of atrial flutter as being an atrial rate of around 300. So monomorphic VT at 300 beats per minute or above, ventricular flutter. And then if you have a polymorphic ventricular arrhythmia greater than 300 beats per minute, what do we call it? That's ventricular fibrillation. Okay, so that's pretty simple. You know that. So as far as classification is concerned, you look at this run and you say, that looks monomorphic kind of sort of here. It does change a little from one beat to the next, but then clearly it changes in a big way. The beats become much smaller. I don't know what's going on. Help me out, Dr. Nick. Well, okay, there's one thing that I left out very conveniently because you guys were supposed to do it. Oh dear. You guys were supposed to make all the measurements, and maybe you did, maybe you didn't. You guys who know how to read ECGs should have pulled out your calipers. Let me pull out my trusty calipers and notice that the QT interval of this sinus beat over here in the beginning measures out to be a whopping 700 milliseconds. Oh my goodness. 700 millisecond QT interval. You better not go back to sleep. Let me tell you, something bad's happening here. So with 700 milliseconds, and then this tachycardia starts up, what's the first thing you really need to think about? Look, you got a long QT interval. You have a polymorphic VTach. Almost certainly what this is you guys know, right? Torsade de pointe. Okay, what is torsade de pointe? It's actually a French word, and it means revolving around a point. It's a polymorphic ventricular tachycardia that was named because the complexes seem to get bigger and smaller and bigger and smaller, and the idea is that the axis of the tachycardia seemed to be kind of spinning around in space, and that's why they named it this way, torsade de pointe. It's kind of a cool name. But when you look in the textbooks, you'll usually see a polymorphic VTach that gets smaller, and then it gets bigger, and then it gets smaller, and it looks very classic. In all the books, it looks the same, and that's kind of not what this looks like. But it is. It's torsade, trust me. Even though it looks sort of fairly monomorphic in the beginning, clearly the morphology changes, and what's happening is the axis changes, and that makes the QRS much larger initially in this ECG lead, but then when the axis shifts, suddenly the QRS gets much smaller because it's going to be bigger in a different lead, right? So you got this polymorphic non-sustained VT. It can become sustained, and it can sometimes degenerate into ventricular fibrillation. Torsade can. But what's causing it all? Well, this really, really long QT interval, I think in this particular patient, the cause is the drugs. So what you're dealing with here is something called the drug-induced long QT syndrome. Dillquits. Right, drug-induced long QT syndrome, because Effexor is known to increase QT interval in some patients, and certainly Levaquin has been reported to increase QT intervals. So you got the combination of two agents, and most of these patients actually have the genetic predisposition to reacting badly to these drugs, and that's what causes the QT to get longer. All right, but let's kind of talk about torsade for a couple of minutes. I just want to get you guys thinking, how do you recognize it? Well, we'll get rid of the tracing and we'll get rid of some of this stuff, and I want to sort of draw a little torsade on the paper here, because torsade has a very characteristic appearance. First of all, when you look at the QRS complex, it's usually narrow, but the QT interval is very long. And that's usually a precursor of torsade. You really have to see a long QT. Sometimes you'll see big U waves, especially. Now, the other thing that's characteristic of torsade is that it's pause dependent. What do I mean by that? Well, what happens to the normal QT interval when rates get faster? Okay, let's think about this. When you have a slow rate, the QT is generally longer. And when you have a faster rate, the QT generally shortens. That's why we correct the QT interval by using this QTC, or corrected QT interval. So generally after a long pause, the QT will usually get longer. But in torsade, you'll see that the T wave becomes really bizarre after a pause. So let's say you have a PVC here, and then you have a compensatory pause. After that pause, the normal beat comes in, but if you look at that T wave, it's really big and long and with crazy U waves and so forth. And then what you usually see is the first beat of the tachycardia arrives from the the T wave or from the TU complex. And the first beat of the tachycardia arises from the T. So because the QT is long, what that tells you is the first beat of the tachycardia is widely coupled, sometimes 600 milliseconds, which is equal to 100 beats per minute. That's common. So you see this widely coupled beat. That's the first beat of the tachycardia because it's arising from this QT complex, which is very long because it's following this pause. So you've got the long QT, you've got the pause dependence, you've got the bizarre T wave after a pause, and the first beat of tachycardia is widely coupled and arises from the TU complex, and of course it's polymorphic at rates usually in the range of 150 to 200, sometimes 220 beats per minute. So this is classically what Torsades comes from, and if you guys want to do some more research into early after depolarizations, if you do a cell membrane, transmembrane potential, it's these early after depolarizations that cause the beats in Torsades. But if you go on my website, I'll be talking about mechanisms of arrhythmias, and triggered activity or early after depolarization is going to be part of that discussion. So stay tuned for that. In the meantime, if we get rid of this and bring our tracing back, you'll see that indeed following this pause, you have a very long, bizarre T wave with a QT interval of 700 milliseconds. The first beat of the tachycardia arises a very long coupling interval, and you've got this periods of monomorphic looking, but it really is polymorphic because these beats are much bigger, then it gets smaller, then it gets much smaller, and then of course it gets bigger again. So you got this polymorphic VTAC. This is classic Torsades, but it doesn't look like the textbook. That's what I'm trying to do, is get you guys to understand that not every ECG looks the same. They don't all look like the textbooks, and that's why you need to watch these Chalk Talks and go on to ECG Academy. So let's figure out what the answer to the question is. It's not A, because we've already figured out it's not artifact. You wouldn't give IV cardizem because it's not an atrial arrhythmia and you're not trying to block the AV node. You certainly would not give amiodarone, because what does amiodarone do? It increases the QT interval, and that would just make things worse. The answer is none of the above. What you would give for Torsades is magnesium. That's right, a couple of grams of magnesium will help to settle this down. Of course, you remove the offending agent, and you get the patient stabilized in intensive care. It's a serious problem, but it is reversible. So that's Chalk Talk number 9. Remember, go to ecgacademy.com to learn everything from basic to advanced, to read ECGs. I do want to make you become an ECG expert, but also subscribe to my YouTube ECG Doc channel so you'll be informed as soon as I do my next Chalk Talk. Meanwhile, thanks for listening. See you soon.